All right. So I think we should just get started here. I want to welcome everyone to our third annual Primary Care Leadership Forum. I honestly thought when we did this last year in Zoom that would be our one and only Zoom forum. And I think we had intended for this to be initially live, then hybrid, and then we just said, nope, we will give in to COVID and continue to do a hybrid event here. So we will aspire to that our fourth forum next year, we'll put it down now, will be a live event for us and return back to that, because I think there's an opportunity to be able to gather as leaders and folks that are interested in primary care leadership. It's great for us to be able to get together in the city. So I want to welcome everyone. It's our privilege here at Atrius to host this event, which brings together thought leaders, policy experts, educators, and care delivery innovators to share some of their insights and reflections around primary care practice, both locally and nationally. My name is Joe Kamara. I serve as Chief Medical Officer here for Atrius Health, and myself and Dr. Daniel Nelson will be co-hosts and moderators of this event for us, this forum. It's a thrill for us to be here today, and we expect a pretty broad range of conversations. But before we jump to have Steve open in, Daniel, do you want to quickly introduce yourself?
Yeah, absolutely. So I appreciate the opportunity to be here with you all today. So I'm a third-year resident with the Atrius Health primary care residency. Very fortunate to be here with you all today. I think, you know, as residents, we are so deep in the trees of patient care that we don't often get to reflect on where the forest is standing. So appreciate the opportunity to learn from some very talented forest rangers today.
Well stated, Daniel, well stated. And just quickly, I know most people here are probably familiar. We at Atrius Health, we're a independent multi-specialty practice with close to 600 physicians serving in 30 different specialties, serving 750,000 patients here in Eastern Mass. We're a national leader in value-based care and have been seeing patients here in the Commonwealth for a good part of almost 5+ decades. We've been sort of deeply committed to value-based accountable care since our roots did come from Harvard Community Health Plan back in the 1960s. And today, over 80% of our overall revenue comes and is generated through risk-based contracts, which kind of sets us apart from most other medical groups here in our marketplace. We are a bit of a unicorn there, both locally and nationally, but we're proud of our position, and we think it aligns very well with how we think about clinical medicine and how we practice. In any case, quick overview of the afternoon and have Steve say some words. We're going to kick off with Dr. Chris Kreider, who, along with a major regulatory role, brings some deep experiences in technology innovation and really around sort of some of the drivers around how we can be using technology to really challenge the current paradigms around care delivery. We'll then continue on in a similar theme a little bit with Dr. Eliza Shulman, who will share some of her perspectives, both as a geriatrician and a PCP, but also as a national leader in the home-based hospital care space, as CMO of Medically Home. And after a quick coffee and bio break, we'll return to hear Professor John Kingsdale share his thoughts about the pros and cons of value-based care, and then wrap up with our dear friend, Rachel Wilson, who is currently president of CIC Health and was in the center of the action with Atul Gawande, leading the state's efforts around the mass COVID vaccination and testing efforts. So before we begin with our first speaker, I'd like to invite our CEO and president, Steve Strongwater, to share some opening remarks. Steve.
Joe and Dan, thank you so much for putting I could not be more excited about the symposium, and I could not be more excited about the future of primary care. It is hard for me to say that, having watched year after year with the numbers of primary care docs dwindling in this country, but I am super excited. The nation is increasingly moving towards value-based care, and primary care clinicians are at the heart of this model of care. I would say primary care's time has come. Barbara Starfield laid out the essential elements of primary care, meaning first contact, continuous, comprehensive, coordinated care, along with long-term trusted relationships. Turns out these are the foundational elements for population health and value-based care. So For those of you who are interested or you're practicing, primary care is in. You will hear, I'm just going to echo Joe's comments, from some very special, important speakers who will touch on a range of topics. My special thanks to Chris Kreider, the founder of New Era Medical Organizations and executive chair of HIGI, a consumer engagement and measurement company, to Pippa Shulman, chief medical officer of Medically Home, to John Kingsdale, senior strategy advisor of Wakely Consulting, and of course to Rachel Wilson, who we know so well, president of CIC, and the role that they have played, critical role in vaccinating literally millions of people against COVID. Thank you again. You're in for a treat. Enjoy. I turn this back over to Joe and Dan.
Perfect. Thank you, Steve. And without further ado, let me say just a couple of words to fill in. Chris, I won't repeat everything that Steve just said, but a quick bio, and there's a more formal, extensive list that I think Jenny and the team have sent out to everybody. But it's a real privilege to welcome Dr. Chris Kreider to kick off our forum. Dr. Kreider is a primary care clinician, did his medical training at Georgetown and got an MBA at MIT Sloan, and practiced at MIT Health Services for almost 2 decades before arcing his career over into health technology innovation. And he's been a very, very successful entrepreneur, having founded the analytics vendor D2 Hawkeye, which sold to Verisk Health, then Generation Health, which sold to CVS, and now currently starting the New Era Medical Organizations. He also serves as the executive chair of HIGI. Did I pronounce that right, Chris? HIGI?
Yep, you got it.
Got it. All right. As Steve mentioned, a consumer engagement platform company based in Chicago. He was also an executive partner at Boston-based Flair Capital alongside our colleagues like Gary Gottlieb, and is an active member of the Harvard MIT HST program. And finally, but not least, in 2018, he was appointed by Governor Baker to serve as a commissioner on the Mass Health Policy Commission, and of course, a super nice guy to boot. So without further ado, Dr. Kreider.
Thanks, Joe and Steve and Daniel, and thank you everybody for your time today. And indeed, I think Steve said it right, that the time is now for primary care. And look, I've waited a long, long time for this, but I'm going to talk today about a few things. I'm going to describe my professional path. Joe asked me to talk a little bit about that. I'll offer my perspective on why I think primary care is ascendant now, and about the technology required to support that, and then talk a little bit about what's happening in the marketplace. But I want it to be informal, and people can butt in if they want to. And suffice to say, I've been a physician for 40 years. I just think it's a wonderful profession, and primary care has given me so many opportunities, and I've been lucky along the way because I found some role models along the way, and they've been often lacking in the fee-for-service, specialty-dominated world. I was slow getting to medicine. It took me 7 years to get through college. I was a history major. I worked in a hospital at nights, grew up in Buffalo, New York. And I was exposed to what wasn't great medicine in the hospital, and it gave me the confidence to decide to move away from liberal arts. And as Joe said, I went to Georgetown Medical School. I got interested in policy while I was there. I came to Harvard with a primary care program, and the choices then included what Daniel's route at HCHP, and some of the outpatient clinics at the hospital, and also at MIT, which peculiarly was another great primary care site, and it became a great site in part because of HCHP. Going back to the early 70s, the executives at HCHP wanted a place to get their care that gave them a little separation from those that were in the building. I went to business school at MIT. I really loved patient care. I spent the next 18 years doing both patient care, taking care of a terrific group of scientists and engineers and their families at MIT, a corporate HMO. And then I had the itch to become an entrepreneur, and I got deeply involved in analytics. And I'm proud to say that I think D2 Hawkeye was the first company that really tried to or successfully combined clinical and financial analytics. I went through that. It was a great run for a decade or so. And we went public as Verisk Analytics. And that all of a sudden was a little too big and not as much fun. And so I became an investor, as Joe said. And then COVID came along, and I didn't expect to be operating again, but the combination of several technologies, which you all know well, remote monitoring of patients, and telemedicine, and the virtues of risk contracting, all of that really, I think, came together at a moment that finally gave primary care the lift that was inevitable. I'm gonna show one case study, one slide. If I can have the if I can have control here.
Let's see, you got it?
I think I got it.
Okay.
And I'm going to show you something that you all know, but hang on just a sec. Are you looking at a screen of a patient?
We are.
Yeah. So in our new company, we have a lot of case studies that demonstrate dramatically the virtues of primary care. This guy tripped over a curb, bruised his face and injured his thumb. And in a fee-for-service world, here's what would have happened. I'll let you take a quick look at that. How do you like the Tylenol and codeine for 160 bucks? But that's what it is. All of these visits, hand surgeon, physical therapist, cardiologist, where's maybe the neurologist, who knows? But this is what happens all the time in the absence of a trusted primary care relationship. When there is a trusted relationship, this patient called his docs, one of our guys. Vital signs were transmitted, had been all the time because the guy had hypertension. It was a video encounter, no loss of consciousness, a remote cardiovascular neurological exam, spelled wrong, Neuro, range of motion and so on. This guy was okay. There was no fracture of the orbit. There was no, the reason he fell down is he tripped over the curb. He didn't have an arrhythmia. The tennis ball for physical therapy and the Neosporin cost a little money, not much. And the time that's saved so anyway, I could go on, but I think these are the kinds of things that we need to really push to recognize the virtues of trusted relationships. So why is primary care ascendant? There are a lot of organizations, probably about 1,000 around the country, and preeminent. And I say preeminent because there's probably only a dozen organizations like Atrius, but that are primary care centered, multi-specialty. There's a lot of PHOs that we think are going to emerge as POs. Some of them are happening in the form of clinically integrated networks over on the far right of the screen here. The problem, of course, is that when these organizations come out of a hospital setting, there's the ratio of primary care to specialist is not the ideal 1-to-1 or 2-to-3. It's more like 1-to-6, right? So there's a challenge ahead to right size the primary care component of these networks. The stakeholders going forward, right now, that cause primary care to jump ahead. First and foremost, I think, is the physicians. It's not out of arrogance. It's because, this is because physicians read their patients. And nobody reads their patients better than primary care physicians. There are lots of other people who participate in care, and they read patients too. But the tightest bond is for those of you who are providing primary care. You can listen to all the symptoms and all the signs, and you can't figure out the headache. And then finally you have to probe and find out what's wrong with the marriage, or what's wrong with the money, or what's wrong with something else. I know that I'm preaching to the proverbial choir here, but primary care guys do this. And generally physicians are so siloed that they don't. So the money is shifting. I'll talk a little bit more about that. But the first two stakeholders are both at their peaks of dissatisfaction, I think. We see this, the company that Joe and Steve mentioned at the beginning, Higgy. There is such fragmentation of care, and I could go on, but the reason primary care is going to grow faster and is beginning to show in terms of investment, and Optum's investment in Atrius is one example of it, is because the system is just so preposterously complex. And patients and doctors are both tired of it. The government, interestingly, describes regulatory support for primary care, for telemedicine, generally for telemedicine, and for the shift to risk. And Republicans and Democrats you don't read about it, but they are fundamentally together behind the reality that the government can't spend 1.2 trillion for Medicare is expected in 2025, and Medicaid is $700-800 billion. It just can't. You can't print money ultimately, and the government, the parties both understand that. And then I think the other thing is that the technology now has finally broken out. It didn't break out before in a fee-for-service system because it didn't fit the business model. Fundamentally, the business model of hospitals to get people in and do stuff, do tests, do procedures. Instead of removing low-value procedures, they double down on low-value procedures. The things that those of you who work at Atrius have been trained not to do because they're called low value for a reason. So the technology, the regulatory environment, the docs and the patients are the stakeholders. And in my view, anyway, and this is it's a bias, that hospitals aren't on this list of stakeholders. I mean, I think hospitals do wonderful things, but in the attempt to become integrated delivery systems, they're not. They haven't created integration. They've created more disintegration. They've done a terrible job managing physician practices, and that really means that doctors and primary care doctors have three choices. They can go to work for a hospital, but try to find happy, well-managed practices at hospitals. You're going to come up empty. You can go to work for an organization or partner with an organization like Optum, and that's a very worthy route, as we know. And 50,000 physicians have chosen to do that over the last, I think around a decade. Joe can tell me, probably answer that better, but Optum is growing. And by the way, I think that describes a really interesting, an unexpected alliance between physicians and payers. It used to be that the alliance was more between physicians and hospitals, but I think that the hospital represents the common threat for both payers and for physicians. And the opportunity now to move care out, and you're about to hear more from Medically Home. We can all see it, and now the technology is there to support it. Let's see, a couple more comments, and then I think, Joe, I should just be quiet, and you should try to pepper me with some questions. There is real momentum right now because the incumbents are struggling. The reimbursement in fee-for-service is increasingly shrinking. So the movement to risk requires gatekeepers. PCPs are the gatekeepers. The incumbents are going to be playing a lot of defense over the next decade as the world turns, but some estimate that that's $1 trillion is going to shift from hospitals to the community over the next 10 years. There's a lot of evidence that physician-led organizations achieve much greater savings than ACOs, Atrius being among those that have done quite well. There are a lot of new primary care companies that are merging. And by the way, financing, one financing stat is that in Q2 of 2019 and 2020, there was something like $10 billion invested in physician organizations. In the first half of 2021 alone, 10 times that amount of money has gone into physician groups. So, the money is a pretty good proxy of where it's going. Lots of new companies, locally in Boston, Iora, Chicago, Oak Street, Florida, Millennium Partners, and Kano Health, Ohio, Agilon.
You ready?
But a lot's happening right now. It's exciting. I thought it was going to happen 30 years ago. I was wrong, but it's really happening now. I'll stop and take questions.
Chris, thank you so much. I'm going to jump in here and then allow folks just to sort of be able to type in questions into the chat, and then Maddie and the team can sort of help us feed through. But maybe I can open it up and say, you've had a lot of experiences, Chris, across multiple sectors, both as an individual delivery sort of physician, as well as sort of thinking about raising capital to initiate new activities in this space. Outside of sort of the amount of money that's now driving through, because I think it's a jaw-dropping amount that's coming in, specifically around physician groups and primary care, what is it that sort of you see is the number one true, quote, I can call it business opportunity that's in front of them that is making everybody want to take these investments and try to plow it into primary care? Is it value-based care? What is it in this space?
Yeah, I mean, it is value-based, but I think value-based is really a stepping stone to global risk. You've been in the global risk business for 40 years. It is, well, let me go back to technology support. So the ability of physicians to communicate with each other and with patients in different forms, which COVID really helped catalyze, I think has shifted the understanding that global risk, taking the entire premium, because there's so much waste and inefficiency and duplication of services and so on, is where it's going to go. And so that has, I think, propelled most of the financial interest. So it's a combination of technology and money. But it's also better care. I mean, my poor man's case study there is not. I mean, everybody can nod their heads at that because they've all experienced it, and there's so much waste. I think COVID just kind of revealed so much of what's wrong with a hospital-centered system. So technology has enabled it, and but ultimately it is the money and global risk. Somebody's going to control that, and I think there's more and more recognition that it's the physicians that are going to control that, and the hospitals can't control the physicians. So,
yeah. Well, so before I sort of ask Daniel to see if he's got some questions here too, if you flip your other hat on, sort of from the regulatory side, and as the Commonwealth looks at all the activity that's happening, and I know you can't speak for the regulatory sort of bodies, but what do you see, and what sorts of things would policymakers be wanting to sort of encourage to help really improve the health of the communities across the Commonwealth?
It's a big question, and just for the record, NEMO is not doing business in Massachusetts, so I can feel comfortable as a regulator in Massachusetts. The big issues in front of us as regulators, the big issue is the MGB expansion, and the questions that are being asked. It's public information. The Attorney General came out a couple of weeks ago saying that she was concerned that consolidation was going to raise costs, it was going to take market share away from the lesser systems. And by the lesser systems, I mean those that take care of more Medicaid patients, for example. So, I think in that statement from Maura Healey, you've got a pretty good sense of where the regulators want to see the system changing for the benefit of the people who really got hammered during COVID. That's poor people and minorities, and to use technology more and better, and to we'll see how it plays out. But consolidation has typically just raised costs, and the communities have not been the beneficiaries. I don't know if that really answers it, Joe, but that's probably the best I can do right now.
Understood. Daniel, turn it over to you.
Yeah, absolutely. I appreciate your perspective. I think, being able to hear from somebody who's been on more than one side of primary care, trying to understand how to both deliver it well and incentivize it well is very helpful. One question that I have, I agree with you that technology has so much potential in improving the care that we all can experience, like the case study you used illustrated. I guess one of the questions that I have that comes to mind is, how can organizations, whether this is physician organizations, insurers, how can they ensure that folks either with low technology literacy or poor access to technology can also take part in the improvements that technology has to offer?
Wonderful question. Well, I think first, by not assuming that there is a high level of lack of capability with regard to technology. Text-based communications have become, I want to say, a really successful currency in Medicaid and kind of unexpectedly. Seniors, 10,000 a day retiring, the back half of the baby boomers are all pretty tech savvy. But I think the answer is it's going to go here. It's not going to be on the big screens. It's all going here. And with the price dropping, and in fact the government providing phones, I don't think it's going to be access to hardware. Now, literacy requires work, and that's an awfully big question, Daniel. I mean, and it starts in schools, right? So, but people respond to video, people respond to simple text, and so much can be conveyed, so much can be reinforced. You can take a SOAP note and have the P can be the clinical plan, and then the second P, the P2, can be the communication plan to the patient, and that that's fixed text, right? That's structured. That can be reinforced by lots of means and connected to educational videos. I'm not trying to diminish that that there isn't a wide variety of abilities, but it is moving inexorably. And if you look back 24 years ago, we didn't have email. So it's moving fast and it's moving in the right direction.
And Dan, it looks like we've got a question coming in from the audience here. And Chris, I just read it here. There's so much focus on behavioral health, especially now, which is incredibly important. And yet it seems primary care providers and pediatricians are not recognized by policymakers as providing behavioral health care and are in fact part of the equation in keeping it seems like are part of the equation of keeping patients out of the ED. Any thoughts on how to show value in this space, primary care as providing behavioral health care?
Well, chronic disease is 3/4 of our spending. $3 trillion. So in Massachusetts, it's $45 billion of spending is chronic care. And as those of us who provide care on the phone know, almost all of that is influenced by cause or effects, stress and anxiety and depression. And so again, I think that COVID has has removed a lot of the inconvenience of bringing behavioral support in to better manage chronic disease. Right now, I mentioned 10 companies that are primary care based. There are probably 50 companies that are digital behavioral companies that have been funded over the last couple of years. I don't like to see behavioral health in a silo. And a lot of that becomes recreational at some point, So I think it's so critical for primary care to bring behavioral support in and have kind of post certification for behavioral support. If people aren't getting better, if they're still depressed or they're still anxious or they're still not back to work, you need more intervention. You can't keep doing the same wrong thing over and over again. So,
Yeah.
I think tech is making it easier. And I was wrong, by the way. I thought the idea of anonymous behavioral engagement was crazy 5 years ago, and I was wrong. And people like it.
Yeah. Well, to that end, Chris, and I know this is probably going to be one of our last questions, unless folks are throwing some more in the chats, but what's the risk that you see that, as everyone dives in, and particularly with more sort of venture-backed sort of innovations coming forth, that people are just kind of taking their slice, that the risk is it's going to just fragment in a different sort of way, but in many, many more pieces than what we've got now. Do you see that kind of risk appearing just because people are basically, they just say myopically, but very narrowly focused in an area that they know they can make a difference and make their cut?
Yeah, that does describe the last 20 years of technology. Little tuck-in pieces that, or worse, terrible electronic medical records. How about that? That's a subject we haven't even talked about. But now, you can get good using lousy systems, but the systems and the fragmentation that have come from tuck-in pieces of technology have made things worse. And I think those days are over. Over is an overstatement. It's gonna, there's people selling products and people buying products still. But if it's not integrated into simple workflow, if we don't have, well, here's the right answer to the question. If we fail to demystify the business of medicine for doctors, if we don't create tools make it easy to understand risk contracts and how surpluses develop, because you have high patient satisfaction and you keep people out of the hospital. And if we don't do that, it'll stay fragmented, and it'll be bad. But I don't think that's going to happen. I think we really have started to turn a $1 trillion corner, and we're going to attract, I hope, many, many more people to primary care because of it.
Wonderful. Well, thank you, Chris. Thanks for kicking us off this forum and sharing your thoughts and your experiences with us. A very unique sort of set of, I know very few people that have done as many things as you have, honestly. And so it's great to have you join us and share a little bit of your time. So thank you very much.
Thank you all. Thanks for what you're doing.
Yeah. All right. So I'd love to introduce our next speaker. It's Dr. Eliza Shulman, or Pippa Shulman. Dr. Shulman is a family physician who's boarded in family medicine, preventative medicine, as well as hospitals and palliative care medicine. So Pippa was our chief of geriatrics and palliative care services at Harvard Vanguard for many years, but is now the chief medical officer for Medically Home, what I would say is the authoritative leader in home-based hospital care here in the United States. Medically Home started here in Boston, but has successfully scaled into a national program with significant investments from both Kaiser Permanente and the Mayo Clinic. Dr. Shulman continues to be entrepreneur at residence in the Center for Healthcare Innovation here at Atrius Health, and of course, also just a wonderful human being and great colleague. So Pippa, can I turn it over to you?
Absolutely. And I am thrilled to be here. And I'm not going to show any slides. So I want to have a conversation. I'm going to talk at you and with you for a little while, and then really want to open it up to questions and hear from the group. There's a lot of friendly faces here and friendly names not showing their faces, which is just fine. I think after almost 2 years, we all have quite a bit of Zoom fatigue. I came into the innovation world really passionate about this idea of you have to understand the problem you're trying to solve. And particularly when we think about patients, what are the ways that we make it hard for patients to receive care in our systems, right? What do patients really want? And we can sum that up pretty easily. Patients want help when they have a problem. And that's often not between 9 and 5 or 9 and 6. Or 8 and 6, or when our facilities are open. Patients want the system to know who they are pretty well, and we make that kind of challenging. I think we've all known for a long time that for the most part, facility-based care doesn't work all that well for everyone. Now I see some of my wonderful surgical-based colleagues here, and I absolutely want my surgery to take place in a hospital. That seems like a great place for that. I chose to have my baby in a hospital. I wanted to have that experience. But when my mom was sick and my mom needed care, she had a hospital stay, but then I made sure she never went back to a hospital, because I knew that if she went back to the hospital, she was highly likely to lose ADLs, to perhaps get an infection, to lose functional status. And I was worried about that. I had seen the unintended consequences of the hospital on my mother, on other patients. I also knew that just being a patient, even in ambulatory care, in outpatient care, is hard and frustrating. Because again, the schedule makes no sense, right? And so I'm interested in older people, and often frail older people, who can find it hard to get to our practices. And so I developed programs where we could go to them, make it easier to get to them. But it's not just older people, it's working people, it's poor people, it's young people, it's all kinds of folks who find it hard to come to us at times that it's convenient for us. And there's long been this assumption in healthcare that centralization of these resources in these buildings with our fountains and atriums and all these things leads to efficiency and reduction of cost. And I think we could all start laughing, because we know that that is certainly not the case. And we watch healthcare costs rise and rise and rise. And it's not just because of the buildings and the fixed costs, but that is a big reason. And so you start to wonder, well, is there another way to do this? Now, I was fortunate enough to go to a residency program where I got to spend a lot of time doing home care. I did home care for people who were dying. I did home care for the elderly. And I did home care, what I would consider home care in shelters for people who needed shelter care. And I did forms of home care for homeless. So they didn't necessarily have homes, but I went to where they were and did care in place, I guess is what you might call it there. And you start to think about care outside of our buildings is considered specialized, right? We open specialized clinics, healthcare for the homeless. We had at Atrius and Harvard Vanguard, we had a program called IHB, Intensive Home-Based Care, for our frailest patients. And you had to meet criteria to get in, but not have certain other criteria that would keep you out, right? And so we think, well, that's expensive and only a certain group of people should get that care. And so I really began to think about, well, what if we turned that idea on its head? What if we started to think about, could everybody get this sort of care? And I'm not the only one, right? If you look out into the world of private equity and venture funding that's out there, everyone's super interested in bringing care into the home in all sorts of different ways, right? And so we dabbled in this a lot at Atrius, which was really fun. I think the alternative payment models and the ACOs kind of got this quickly and allowed expansion of this thinking. And in early days, sort of urgent care into the home and acute and hospital-based care in the home. And yes, we founded Medically Home with Atrius. And this idea that we could bring acute care in the home, we could leverage this hugely high cost DRG and provide more care for lower cost in the home for a wider group of patients, right? And now we've seen 6,500 patients across the country, and we know on average, we can save over 20% off the hospital cost. And we know that in some of our markets, 40% of those patients are non-English speaking. Sometimes half of them are on Medicaid. This is care that everybody can receive in their homes. And in places where this exists, the virtual hospital is the highest performing hospital with regards to patient satisfaction of every hospital in the network. And I'm not the only one. I have competitors in this arena, and they're all seeing the same thing, which is really exciting. So you start to think about, what is this? What's happening here? What's going on here? So who are the other players in this space? What else are we trying to disrupt? All right, so hospital. What about the ER? Can we disrupt the ER in this space? So our partner, we have colleagues at Dispatch Health. They've been doing this in Colorado. Medically Home is doing this here in Massachusetts, again, with Atrius, and now at other places in Colorado and elsewhere. ED in the home. Let's just bring ED services into the home. And really showing that for undifferentiated patients, you can walk into a house with a paramedic tethered to an ED physician using technology, and not super complicated technology. We're not using rocket ships, it's cameras. It's some cool ultrasound, and point of care testing. And we can avoid a huge proportion of admissions to the hospital or even just ED visits. And again, at lower cost with great patient satisfaction. All right, so what else can we do? What other parts of this facility-based care can we interrupt? What else do patients need if they have a problem? Now, what else is going on, right? So you've got all these players in this space. There's this shift in healthcare over the past few years, and I think we haven't named it well enough. And what all the entrepreneurs are realizing is that healthcare is not a service economy, right? And I don't think healthcare has realized this yet. It's actually the experience economy, right? So when you go to the doctor's office and you're frustrated because it's annoying, and you call and they don't know you and it's frustrating, you're annoyed because you're not comparing it to the last time you saw the doctor. You're comparing it to the perfectly seamless Amazon experience you just had, or to the time that someone in the store knew exactly who you were. And healthcare is not caught up to that. And so that's why you're really seeing this shift and all these new startups in this space that initially are really appealing to this commercial market, right? The One Medicals were kind of the early entrants into this, the Ioras, right? Where they know you in this new way, and they offer these new ways of interacting with the healthcare system, still kind of tying you to a facility, but offering a new way to be known using text and video and email and other ways to create access. And now we're moving into virtual first models where the link to that PCP is much more tenuous. It's really just what's convenient for me and not tied to that building at all. And so where is that line between the bricks and mortar and the virtual space and what actually needs to be there and what is the definition of primary care. And that's what I've started to think about a lot. And how do we move past, all right, so some of these new startups and a lot of these new entrants are really interesting. And there's a lot of activity kind of in the commercial space with these primary care startups, a ton of activity in the MA space and the Medicare Advantage space. And we've heard about some of those and ChenMed and blah, blah, blah. Some activity in the Medicaid space, although a little bit less, and people are not sure what the big win is there. But what's the next frontier? Where are the interesting problems? And what I start to think about is, what is the definition actually of primary care? What are we talking about when we talk about primary care right now? If I'm a primary care doctor, I don't want to give up that moment when I sit across from my patient and have that conversation, have that hard conversation or that good conversation or that moment with my patient and their family where I might be holding their hand and having good news or bad news or sad news. Those are the reasons we got into this, right? To help people or to create those relationships. I'm a family doctor, and so I've taken care of entire families throughout the life journey. And that's incredible. I don't want to give that up. But I also know the power of the experience of a patient being able to call the practice, be short of breath, have the ED and home visit go out to their house, realize that they're having a CHF exacerbation, give them a dose of IV Lasix in place, actually admit them to the home hospital, care for them for a period of time, and discharge them. And the PCP wasn't involved at all until after that experience. Now, what should happen after? That patient's at really high risk of hospitalization again. Should we just take everything out of the house? Or should we perhaps leave something in the house for the patient to call on again? So this brings us into the whole universe of RPM, which lots of people have thrown tons of money at, and there's no evidence that any of it works, right? It works for a short period of time, and then it's just garbage money. Truly, go look, read the papers. It's like, there's nothing there.
Yeah, but
So what do we
RPM
do
being-
with that?
RPM being
Remote patient monitoring. Yeah. Remote patient monitoring. So everyone wants to do remote patient monitoring. You'll hear a lot about remote patient monitoring, and big companies are getting into this. I just was having a conversation with Verily, a Google Alphabet company, right? They are all trying to figure out, can we prevent the event, right? The problem is with remote patient monitoring, you're monitoring, and then you're detecting a signal of something that's already gone wrong. We still don't have the early enough signal of the 2 weeks before the thing has gone wrong. And so that for our heart failure patient, once we've detected the weight gain or the shortness of breath, as my colleague, Dr. Jesse Yang, I don't know if he's on today, the horse is out of the barn. We didn't actually solve the problem. We needed 2 weeks before to kind of understand the issue then. And so that's the trouble with remote patient monitoring. So is there some way we can be in that patient's life earlier? So there's this whole universe out there and tons of money being poured into the sensor market. Well, we'll fix this with sensors in the home. And I can't tell you how many times I get pitched the newest wearable, and I'm wearing all these wearables, right? I'm trying them all out. Patches, I got watches, I got bath mats, toilets that weigh you, cameras that watch you. Now, ask yourself, and maybe some of you have given yourselves up to Jeff Bezos and the guys at Apple and your privacy. Maybe that's fine, but your parents may not want to, and your kids may not want to. And does any of that really work, right? And so, no. Other about the camera people is they design the cameras. So these are often cameras that watch and they're looking for gait abnormality, and they can detect early onset issues of different things by gait abnormality, but they've tested them in hospital rooms, which are really helpful because they're of uniform size and generally have no furniture and are a uniform color and have no clutter, which is terrific if you live an ascetic life with nothing. And so I always ask, well, what about pets and people and stuff? And they're like, yeah, well, we haven't tested in those environments anymore. So I just love all of that, right? So we've got all these sensors out there. And again, so we've got remote patient monitoring, we've got sensors, we've got patches and pills and watches. And we're still not figuring out how to get at this thing. And we're still not helping the patient. And we're still not helping the primary care doctor. And yet we're all trying to move all of this into the home. So there's something on the next frontier that I'm trying to figure out, that I'm working towards. And it's got me playing around a lot recently in places like Oklahoma. So let me tell you a little bit about Oklahoma, where I've spent some time. So look away from the coasts, right? We spend a lot of time on the coasts. So in Oklahoma, there's a couple counties in Oklahoma. Their statewide ED visits per 1,000. This is how we measure stuff like this. 1,500 per 1,000. It's a big number. Yeah, it's a big number, right? Because their primary care system is basically fallen apart, right? And they believe that about 70% of what's happening in these ED visits could have happened in primary care, but people have access issues because of distance to travel, or they're traveling out of state. They're driving more than 50 miles for care. So it's like it's like a stretched out problem of what we have in our urban cores, where we just have like primary care docs with 5,000 patients who don't have time to see all these patients, right? Now we've got places where there's just not enough. And so the distance traveled is much, much bigger. And so what is primary care? How do I capture that moment? How can a company like mine, where we sort of started in this acute care space, we've moved into this ED space, maybe we're doing some longitudinal, what could we do to support primary care, to enhance primary care, to make primary care really stand at the forefront of the care system again, and to really try to interrupt this care journey? And so one of our theories, and again, I don't know if this is right, but this is how we're starting to think about, innovation in the pandemic age, right? We really do believe that if you push on decentralization of care, if you believe that home is where the healthcare takes place, which I do, I fundamentally do. If you believe that, we think that if you offer more touch points to patients, all right, what are touch points? A touch point could be a telephone call. Maybe it's a visit from a community paramedic. And what's nice about community paramedics is it's a pretty short training window. And so you can train local providers in a town pretty quickly. They could look like the people from your community. They also, people come out of the military, many times are trained as paramedics. So you can train a community paramedic to do some touch points on patients. You can train community health workers, right? So how can you create touch points for patients that might be asynchronous, that might be technology, that might be in person, that might rely on community organizations? How can you use networks of critical access hospitals or religious places? And we're not the only ones thinking about this, right? Tethered back to some place that can actually have a way to intervene on that patient. Because that's fundamentally what I think is missing from a lot of the monitoring that's happening and a lot of the programs, is there's no way to intervene. And we believe that if you can intervene, if you can change that trajectory, you actually can make an impact. And that's what we're trying to do. So we believe that if you provide more care, more touch points to the patients, you may actually lower utilization, because patients want help when they have a problem and they want to be known by the system. And so can we help build up those relationships again by offering more to patients at their more vulnerable times? I don't know. It's a theory. So we're going to test that.
Yeah.
And so I put that out to you and this smart group. I just wanted to be provocative today.
Yeah.
So that's the story that I'm telling you. I think it's a really exciting time to be in primary care. It's a really exciting time to be in health, IT, and technology. It's a really exciting time to be in innovation. And so I invite you all to join in, and I'm really, really looking forward to the conversation. And I thank Joe for the invitation and for Atrius for sponsoring. So thank you very much.
Pippa, that was awesome. But let's jump in specifically to one of the things that you just raised. One of the things that's hitting all of our primary care clinicians, and actually all clinicians, right, is it's almost like we're drowning in inputs already. Mm-hmm. So when you talk about a world where suddenly you are able to monitor people, no matter how smart it is, we are further expanding those inputs, right, that come in. how do you see that evolving? Like, what is there like? Is it going to asymptote? Like, what do you see as you project forward there?
I mean, I think the question is what actually reaches the clinician, right? And how do you put the gates on that so that the information that the physician gets is clinically actionable? That's the whole thing.
Mhm.
And that in fact, the things we need to monitor are probably much, much smaller than we're actually monitoring.
Mhm.
And that really what we need to do is actually do things like asking patient symptoms and functional status questions rather than checking vital signs.
Mhm.
And so I think sort of, yes, we have a lot of technology. I think we're using it in some of the wrong ways. And then I think we need to really ask, how do we provide clinically actionable data to physicians? And then everything else stays away. Now, this is where all of my colleagues in tech are like, this is the AI engine. It's just not ready. Like, there's just no AI that's doing this right now. Someday, maybe. Sure. And this is the opportunity for machine learning, but the machines aren't learning yet fast enough for it to be viable.
Yeah. Daniel.
Pippa, thank you so much. This has been very exciting. Your vision for what care can be delivered in the home is like, far beyond what I've ever considered. So very exciting to hear you talk about it. Just a question or two for you. So, the pitch that you can make to a patient that, hey, we want to get you in better touch with your primary care doctor. We want you to be able to have access to contact them all the time. Boom. I buy that hook, line, and sinker. I have no concern about that. I can't imagine a single patient not saying that, yes, I want that. One of the questions that I've got for you is how has that pitch gone for patients that you approach for hospital in the home? From the inpatient side of things, there are many patients who, we get pinged by the Brigham's version of hospital at home, saying, hey, we approached this patient, they don't want to do it. I'm curious if that's been your experience as well. How have you been able to help patients get over that concern that, oh, my home isn't a safe enough place, I need to be in the hospital?
So great question, and one that comes up a lot. I would say that, excuse me, for our partners, the acceptance rate for patients is well in excess of 94%, something that we measure quite closely. First of all, if a patient's ever been in the hospital before, when you approach them and ask them if they'd like us to bring the hospital to them, they are absolutely on board, because no matter how good your hospital is, they would not like to return. I think the numbers had some challenge in time of COVID because patients sometimes didn't want to bring COVID home, although many patients knew if they came into the hospital, they would not get to see their families. And so the data got a little bit cloudy. But in general, when you talk to a patient and you approach them and say, you are sick enough to be in the hospital and you are so lucky, we have the opportunity that we can bring the hospital to you. Would you like to be considered for that program? Patients are actually really amenable to hear more. And we've done a lot of our partners have done some wonderful things with videos and patient testimonials so that the patients can actually hear from other patients what it's like. It is hard to explain to a patient what this is. And so being able to open a card and see a video of a patient is really, really helpful in those moments, and doing a lot of marketing like that. And so the acceptance rates are very, very high. What's interesting though, is it requires, before go live, and I'm in Delaware right now with a health system partner getting ready for their go live. And we spend a month doing simulations, training, and sort of change management readiness for go live. And if you don't do that, and this is on top of like the 4-month implementation process, and a lot of that is, sitting down with the ED docs and the hospitalists and the referring physicians and the specialists, because we want everyone in that hospital from senior leadership on down to be 100% committed that 20% of their volume should go home. Because if everyone in that hospital is not committed to that, their program is not going to be successful. And once you get there, once everyone believes this is a viable option, and yeah, okay, there's laggards, fine. Then as they present it to patients, they are presenting it as a viable option from the jump, and patients hear that. Where we run into problems is, there's this new home program. Like, well, I'm not gonna do that. And so we've gotten really good at being able to offer this. Patients always have a choice. Patients can, of course, but I think we've had really good luck with acceptance.
I appreciate that. I will say that acceptance rate is much better than I would have estimated offhand. One of the other questions that your presentation has brought to mind, and I'm very curious to hear your perspective on this, given that you've worked in so many different settings, taking this care in place idea for folks who are unstably housed is very intriguing. One question that I have for folks who don't have an optimal home environment, whether that's, caregiving responsibilities themselves or who are otherwise being cared for other people who live in the home, how do you think about making sure that this isn't just us shifting more caregiver burden on the household members of someone in their home?
That's such a great question. So one way to do that is to make sure that as part of the consent process, you actually consent the others in the home, right? You want to make sure that everyone there knows what's going on and is involved in the decision making. Because even if you say we're going to provide extra support, we're going to provide a home health aide, we're going to do this, that, or the other thing, you're still asking something of folks in the home. And as we know, there are a myriad of reasons people go to the hospital, and some of them are because the family's tired and have nothing to do with the medical reasons. I think there are also ways that some of our partners have used respite sites to provide care that are really, really creative to actually just take the patient out of the home environment but provide a different home environment. Now, CMS has been a little bit blurry on whether that's okay. We had one of our partners asked explicitly if they could do this, and CMS said no. We had another partner ask, and they got a different answer. And so I think it would be really terrific if we could get some clarity on this issue, because that is a terrific option. I know there's programs, for instance, like Boston Healthcare for the Homeless, that is thinking would really love to do this with some of their respite beds, being able to actually provide hospital level services rather than just post-acute services, using floors of the hotels. I think, we saw some failures of this during COVID with some of the COVID post-hospitalization, but I actually think there's some real opportunity, and we've seen some good success with this with some of our partners in California.
I'm sorry,
for
what?
instance.
Okay, I got the thing.
That was just sharing. Keep going.
I know. That's okay. Hi, Amy. She's waving. Let's get Amy.
Amy, go ahead.
Okay, so first of all, PIPA for president. I mean, PIPA for president. That's all I want to say. Well, actually, I have a question. So I come to this from a very naive perspective. So I'm going to kind of qualify what I'm going to say, because maybe it's not on point. But a lot of what you shared has given me a lot of thought. And I'm wondering, I don't know if it's possible, but have you been able to study in any way what components of the care you've provided in the home that patients deem most valuable? Because my suspicion is it's not actually the Lasix or the antibiotics that they feel was the form of care. And I ask that because if it's possible to assess that, I mean, some of the care you're providing in the home, and I imagine some of the benefits of that care has to do with providing things that people need in order to be cared for, that I wonder if we could address as a society to elevate kind of healthcare in general, right? So anyway, I just don't know if you can access granularly what components people are saying, yes, this was incredible and this changed my health and my approach to care.
Well, so this is something that we're actively studying, is sort of what are the components that work, and we're doing it in 2 different studies. And I will say that one of the elements that comes up a lot, and there's a lot of Atrius people, so I'm going to poke the bear on this because it is something that we talked about at Atrius a lot, was people over and over again said, I knew when I picked up that phone that someone would answer it any time of day or night and could answer my problem, my question. And 95% of those questions are, what time is someone coming tomorrow? Or how do I take this medicine? It's not related to something complex, or, they just wanted to talk to somebody. That single point of contact, that is what people really, really want. They felt like they were cared for because someone was always on the other end of that phone. And I think that's huge. And we did a really small pilot where we just gave folks a phone number, and told them to call it before they went to the hospital. This was like 5 years ago as part of the Atrius Innovation Center. 40 patients, gave them a phone number, and we saw like their ED usage plummeted because we gave them a phone number and told them somebody would answer it, right? Like that is an intervention that works. Because we don't do that. We train people that we make it really hard to get in touch with us. And that is so sad, but really true, right? It's just really, really hard. I also, I think the knowledge that someone is there, monitoring and watching is helpful. There's people that keep like my mother-in-law used to keep expired medicines in her medicine cabinet because it made her feel safe. Like it's the same kind of thing, right? Like, well, you're there, it just makes you feel safe. I think there's an element of that as well, but we are trying to study that so that we can actually write that up and make it more academic-y.
If I could, oh, no, sorry. If I can pick up on that thread though, and I know, please ask the questions, raise your hand if you can do it in here. Maddie and Amal will be looking around for it. But what about that concept? And Chris sort of hit upon this too, around trust and longitudinal and relationships. You're responding to sort of when I dial a number, someone is there, someone who knows me is there, but it may not always be the same individual, right? As you're going over time, how do you sort of reconcile that sort of cognitive dissonance if it's the same person that I've trusted and seen over time versus someone who definitely knows me and knows all my history and knows what happened the last time, but it's actually a different human?
Isn't that the power of having an EHR with 40 years of continuous data in it? I mean, right? Like we have the tools to do that. We could do that so easily. There are, I'm sure, well, there are patients you don't remember, but you have little places that you keep the notes so that when they walk in next time or they call, you say, "Oh, how are the tomatoes, Mrs. So-and-so?" Right? And that's CRM. Like companies know how to do that really, really well. And there are places in the EHR we could do this. Like we actually have the power to do that. We could do anyway. So
understood. Any questions for Pippa before we wrap up here and take a quick break? Maddie, Amal, are we seeing anything? We're good? Well, Pippa, thank you. Your energy and enthusiasm is infectious as always. I love speaking with you, and thank you for taking the time to share here. We're gonna go ahead and take like a 5-minute break here, I think, and then jump back in with Professor Kingsdale. So please stick around. There'll be some slides being shown here of some quick events, some fun things we've been doing recently and about our practice. So if you want to take a look, that'd be great. But Pippa, thank you so much.
Thanks, guys. I'll be popping in and out.
All right, very good. All right, we'll be back at 4:15. Maddie, Amal, is that right?
Yep, 4:15.
Right. Excellent. We'll see you guys in a bit. Thank you so much. Well, let's jump in. Welcome back, everybody. Thanks for participating. This is our third annual Primary Care Leadership Forum, and hopefully our last virtual one, but you never know. We could head further down the Greek alphabet for ourselves. So, Daniel, let me, before we open up and introduce our next speaker, what are you hearing so far? What's sticking in your mind in terms of thoughts that have come through?
Yeah, I mean, I think there are two threads that you can sort of pull between Pippa and Chris's talks. I mean, obviously the role of technology is obvious, but especially what I'm getting from Pippa is that it's not just something, we can't just throw a device at somebody and expect it to improve care. That we really need to listen to what the patient is saying is important to them in making access to care easier for them. And then beyond that, I think the lesson, it's not a surprising one, but that if we want to push the boundaries on what sort of care we can deliver and really change the way that care looks, we have to incentivize it properly. And I think risk-based contracting is a way to do that. And I know that John's going to talk a little bit more about that, so I won't say much more.
Yeah, no, I think it's a good bridge point. Not surprisingly, both are our first clinician speakers sort of made some assumptions that if the economics are there, here's what we would do with it. But there's a big assumption there around value-based care in the very beginning. And so I think with that, it's a privilege to introduce our next speaker, Professor John Kingsdale. John's had a long and distinguished career in Massachusetts healthcare. He served as a senior executive in Tufts Health Plan for a long time before he was tapped by Governor Patrick, I believe, to serve as the inaugural executive director of the Mass Health Connector. And as many of you know, that Health Connector served as the prototype and pretty much the national model for statewide health insurance exchanges that arose with the passage of the Affordable Care Act. Professor Kingsdale is on the faculty of both BU as well as Brown University, a graduate of UPenn with a PhD in economic history from the University of Michigan. He is currently a senior strategic advisor for Wakely Consulting Group, and in full disclosure, the chair of our Atrius Health Board of Trustees Finance Committee. So with that, John, I'm going to turn it over to you.
Thank you, Joe. Joe, I hesitated. Well, first, I'm actually pleased that this is remote because it turns out somebody I had Thanksgiving dinner with tested positive. So I'm isolating until I can get a PCR test Thursday and my results on Friday. My rapid test yesterday was negative. I have to say I hesitated. And by the way, for those of you not keeping up with the news, apparently the New York Times reported that 10 minutes ago, the first case of the Omicron variant was detected in the United States, but it's a continent away in California, so who cares, right? We're fine. So I have to say, Joe, I hesitated at first when you asked me to talk about the 3 to 5 year future of value-based care for a couple of reasons. First of all, the difficulty of forecasting any complex human activity. And what could be more complex than healthcare financing in the United States, right? In fact, in this country, we can't even agree on the past, let alone forecast the future. And the second reason is I've seen and heard the term value-based care tossed around so often and by so many disparate actors that I'm not always sure what it means. So when I asked Joe, should I start off by defining value-based care? He said, no, everybody's going to sort of know what value-based care is, which really made me feel bad because I'm not sure I knew what value-based care was. But so am I the only one who's slightly unsure about the meaning of value-based care out there?
Help us, John, help us.
Okay. All right. Well, if you'll turn control over to me, always dangerous, I will put some slides up. That'll help me remember what I'm supposed to say. Can I do that?
I think you've got that. I think you've got control of them also.
Okay, great. Okay. I don't see me, but that doesn't really matter. Can you all see this first slide? With their value-based care?
Not seeing the slide yet, John.
Uh-oh. Okay.
If it's a challenge, and does Amal, do you have the slides, or does anyone else have a slide, the slide that he sent over to us?
You know what? It might be helpful if I hit share screen.
That would help.
Okay. How's that?
There we go. There you go. Yes, now we see it.
Okay. Okay, there. Great. Okay, so I went back to the kind of the origins of this concept, value-based care, which Michael Porter and Elizabeth Teesberg, I hope I'm pronouncing that correctly.
Hey, John, can you lean into your mic a little bit? You're fading
Sure.
out there. Yeah,
Sure.
sorry, thank you.
Is that better?
Yes, when you lean in, absolutely.
Okay, great. So this term dates back to Porter and Teesberg in their 2006 book published by Harvard Business School. And it's really about maximizing quality, especially outcomes from the patient's perspective, while minimizing the cost of an episode of care or the cost of care. And clearly that is a little bit different slant on things than our maybe conventional primary care led global budgeting or population-based care. So, you know, clearly it includes secondary prevention. It focuses though on optimizing costs for an episode or a bundle of services. So, you know, a classic example is a poorly functioning joint. And we're looking to maximize functionality, minimize disability time. Probably from the patient's point of view, the first bullet ought to be postpone the whole damn procedure until the pain outweighs the risk. Certainly eliminating complications and redos and waste, all for the least total amount of care cost. Sorry. So, you know, this is related to the AAA, right? Patient experience, population health, and cost of care, but not so much the focus on population. It's really more a focus on, could I, as a consumer, in this case, a consumer of medical care, have a product that I can understand? So it's not a lab value or a minute of anesthesia. It's, you know, taking care of my problem from beginning to end, that I could sort of consume, I could shop for, I could find the best value out there. And of course, it's hard to argue with these aims, and nobody does. You know, when a large multi-specialty group practice, which shall remain nameless, went to seek a strategic partner a year or so ago, all the respondents, including local academic medical centers and publicly traded companies and health insurance plans, they all said, oh yes, we're committed to value-based care. And there's nothing that's a clear indication of confusion than unanimity in the healthcare sector about a goal like value-based care. So what is the future of value-based care? And, you know, the simple answer is, I don't know. Now, with that, having deflated your expectations, I thought I'd at least give you a framework for thinking about that future, because I don't believe in happy talk. I've been around for 50 years. I've seen, you know, prepaid group practice, which would be our saviors, morph into managed care, which would be our saviors, morph into value-based care, morph into population care, patient safety, et cetera, and we're still trying. So here are, I sort of categorize them as internal barriers or challenges or hurdles, and external, and you can argue with the internal, the external, but I think there are at least 5 internal ones to getting to value-based care. One is clearly care coordination, the right care in the right at the right time and in the right setting. And primary care physicians obviously have a key role to play in that. You know, and the academic medical centers, including the ones in our town, talk the talk Optum certainly seen with its 56,000 employed physicians seems committed to that. And clearly part of this is about prevention, and prevention, I would say, has become very, very standard in the physician's perspective in the last 30 or 40 years, much, much more so than there's real progress. And I think that will continue to take place. But the dominant revenue model for the dominant delivery locus, the place where most of you go to learn how to be doctors, is still heads in the bed, right? The number of heads in the bed. And that's not really about value-based care. A second component is best practice protocols. We ought to be able to look up, with reasonable confidence, how do you do this in the most cost-effective way, whatever this is. Building teams around conditions, measuring outcomes for each episode, and measuring cost of care for those episodes. With respect to best practice protocols, there's a lot of work being done on that. And MGB specifically is in this town, Mass General is working on those. Joe could tell you whether, and I should probably know, whether Atrius is developing a library of best practices. Certainly some leading institutions around the country are. But can the average physician, can you as a primary care physician, encountering an interesting, challenging condition that you yourself cannot treat, but you need to refer, can you access, I'm sorry, for something that you can do, can you access a library of protocols for the highest value way to address a challenge? I suspect not. I suspect we're all still learning from the great men and women who taught you and when you were in your second, third, and fourth years of training. Building teams around conditions. There are some specialty hospitals that do that. I'm thinking of Jocelyn, for example. But by and large, we're still organized by orthopedics, rheumatology, et cetera, at traditional academic silos. You work to try to bridge those silos, but it doesn't come naturally. And it's still a little bit like the automobile consumer trying to sort of get the engine maker and the chassis maker to talk to each other and coordinate. Measuring outcomes. There's a lot of work on measuring outcomes, and we're making some progress on it, but it's hard to measure. There was a survey done about 5 or 6 years ago of about 10 different pilots or programs around the country, including the here in Boston, the Blue Cross Blue Shield AQC contract, the reward program that Mass General Physicians Hospital Organization introduced, financial rewards for meeting certain metrics. There's a lot going out in California on this with the IHA and CalPERS and the Pacific Business Group on Health. But only about a quarter of those measures that they used were outcomes or patient experience. Almost 3/4 were the traditional kind of process structural metrics. And virtually nobody's measuring the cost per episode. So we just don't have accounting systems that are built that way. And so there's very, very little there. If you look at external barriers, this is maybe what the payers are doing, what the government is doing. I've got 4 here. You would want value-based care payments. So that can be capitation, that can be affordable accountable care organizations, even to some extent, at least for a series of primary care issues and behavioral health issues, patient-centered medical homes. And then the classic one is actually paying for a bundle of services to treat a particular condition, whether it's a joint replacement or cancer care or something else. And so, CMS, Medicare, is actually doing a lot in this space. And I talked to the woman recently who's newly in charge of experimentation for CMS. And, her perspective was, my goodness, there's so much going on here. And each one of these experiments, each one of these value-based payment approaches, whether it's bundled or patient-centered homes, whatever, has their own constituency, not just outside of CMS, but the program people within CMS. So she's going to be challenged to try to pick the winners and winnow away some of the losers, and then focus Medicare policy actually on the most promising value-based care payment models. And you've got commercial plans that are following in the wake of that. And I mentioned two of them here, IHA in California. But these are mostly dealing with large, progressive, self-insured employers. For the run-of-the-mill health insurance plans, it's still fee-for-service that dominates, especially PPOs and high-deductible health plans. And the most progress you see in those states that wouldn't think of voting for Donald Trump. The rest of the country, and when you look at the map, it's most of the country, is well behind us socialists here in that regard. Government so you don't really see what I think the ultimate vision of Porter and was, which is to see systems and health plans competing on value-based care. You as a primary care physician, I would think, would love to be able, when your patient comes now with a condition that you can't treat, to be able to look up and work with that patient and compare what's the most effective place to get to treat that episode of care, rather than simply refer within your institution, or as a primary care physician to be demanding that data and that information of your own institution and trying to improve it. We don't see a lot of patients flocking to the value-based care champions of the world. The next element is government promotion of value-based care. Again, CMS is doing a lot. I think probably the biggest single factor favoring value-based care, and it's growing and growing every year, it's very positive, is the growth of Medicare Advantage plans. Out of a total population of, 60 million or so Medicare beneficiaries, they had 2 million new enrollees taken out of traditional Medicare and into Medicare Advantage. In fact, most people don't realize this. Medicare Advantage is not really a government-run program. In a sense, Medicare Advantage is it's not really a single payer program, I should say. In a sense, it's hybrid. So, literally about half of the active Medicare beneficiaries, so people who have given up their employer-based coverage. And so that's a lot of people over 65 have not, but the ones who have and are truly relying on Medicare as their primary payer, about 50% of them are in conventional single payer Medicare. Which, by the way, for everybody who complains about single payer in Canada, like Medicare, I don't see revolts by seniors against Medicare. But half of them have chosen Medicare Advantage plans that tend to take a value-based approach to care. On the other hand, there's been some effort in the Medicaid program to do it, and Medicaid is actually a bigger public payer, a bigger public program in terms of bodies covered than Medicare. Not much progress though in Medicaid. And then finally, I would hope that we could have interoperability of our IT systems to promote value-based, to enable value-based care. But I know, for example, I don't know how long New England Baptist has been part of Beth Israel Deaconess, which of course now is part of Beth Israel Lahey, but I think it's 5 or 10 years, and they still can't communicate with each other electronically between the Baptist and the BI, let alone between BI, Leahy, and Partners or Berkshire Medical Center or anyplace else. So lots of money and lots of noise here, but the systems are still struggling. So what do I predict? I want to end with a rock solid forecast. Something's got to happen sooner or later. And I fully endorse that forecast. I do think that primary care physicians have a huge interest in this, in value-based care, even as narrowly defined as I've defined it. Because you play a key role, of course, in delivering and integrating value-based care, but also ideally, at least I would like my primary care physician to be my guide for an episode of value-based care. And I would like my primary care physician to be demanding the data from the various institutions around town to be able to do that. And maybe you're doing that and saying, for my patient newly diagnosed with prostate cancer, where's the data I can point to, I can find on the cost and quality of treatment for that episode of care over the next couple of years or over the next 10 years for that matter. And if you do that, it may have more impact than anything else in developing value-based care. So as usual, it feels like a graduation speech. It's all on your shoulders.
Well done, John. Thank you. Thank you very much. Let me actually turn it over to Daniel first to open up the questions for you.
Yeah, absolutely. I appreciate your perspective on all this, and I must say, especially given this last weekend, it is great to meet a fellow Michigan Wolverine. I was there for medical school, and so I just must say, go blue. I wish that my co-resident, who's an Ohio State grad, were on the call, but I don't believe he is, unfortunately. All right, so we'll move beyond football and talk a little bit more about what you're saying. So I really love this perspective. I think it's important to agree on a definition before you can make progress. And as someone who's interested in how health systems choose to deliver care better, agreed that some people seem to be talking past each other when they're discussing value-based care. One other reflection, I would say that Atrius actually does a very good job at allowing and facilitating primary care physicians to have access to value-based protocols for caring for conditions. One thing that I am very sad to be missing out on when and if I eventually leave practice in Atrius is access to smart sets that allow me to very rapidly see a menu of options for treating a given condition, whether that's depression, COPD, asthma, and doing so at the best value for my money. So that's one reflection. One question that I have for you, obviously I'm interested in the role that government payers can have in promoting value-based care, and frankly, as someone who's especially interested in Medicaid and how we can better deliver care for Medicaid beneficiaries, I'm curious your perspective. Why has Medicaid lagged behind? I mean, aside from a handful of states, Colorado, Oregon, Massachusetts, the landscape isn't particularly bright in terms of Medicaid acting in the value-based care space.
I think there's a couple of factors that tend to make it difficult for Medicaid programs to pursue this. And one is that the nature of the program is such that, with the exception of the frail elderly in nursing homes or home care, there's a tremendous amount of in and out for Medicaid. So whether it's value-based care or care coordination or long-term care management, it's a challenge for many of the Medicaid beneficiaries. And frankly, one of the things that one of the positives, I guess, around COVID is that we actually halted the redetermination more frequently than once a year for Medicaid patients, which is used by many states, and including ours, and has been to cull the rolls of Medicaid beneficiaries. So that's one. The second is that a whole bunch of Medicaid folks are reasonably well. They're kids and moms, and so while there are subpopulations that desperately need care management and sort of a long-term following, a lot of very healthy moms and kids, really, that's not what they demand. And then the third element, which I think is probably the most important, is most states are so strapped financially by their Medicaid budgets that all they can think of is, where can I safely cut my fees so that I don't have a revolt from those physicians that are affected directly by it, and I can still save a few bucks. I used to teach a course at Brown on health policy with Anya Wallach-Rader, which I think some of the people on the call probably know Anya. And she was Medicaid director for a while in Rhode Island. And we'd do a little case study that she was very both comfortable in leading and uncomfortable in the sense that she had to do it every year, which is every year the governor would call and say, okay, how are you going to cut 10% from the Medicaid budget? So that's hard to do this kind of stuff when you've got those kind of financial pressures.
Yeah, no, that's a good insight. I see we do have a hand raised from the audience, so I'll pass it over to Gordon Moore to unmute and ask his question.
John, this was really an excellent attempt to simplify the concept. Thank you very much. It was great. I've always been a little bit interested in Michael Porter's idea that there would be competition based on value-based care between different entities. And one of the questions that I have is, how does that get operationalized? As you describe it, the value-based care is kind of an internal, the insurers, if you will, or the stand-ins for the insurers and the providers. And I'm curious about the patient. It seems to me that ultimately competition is going to depend on patients saying, I want Harvard Pilgrim or Point 32. That's where the competition lies. And I'm curious about your thoughts about sort of whose value is it that we're talking about? And if it's the provider buyer entities, but the patient is important in making the market work, how much alignment is there in terms of the assessment of how we're defining value?
That's it. Thank you for that. Nice to see you, Dr. Moore. Thank you for
it's Gordon.
Your question
Please.
is more insightful than anything I've said. Great question, and I'll probably end up fumbling a response to it. I think that the vision that Porter and Teesberg have is that, like other goods and services that are consumed by the customer, there should be packages of services that make sense to the patient. So patient comes in and says, I've got pain in my hip. What can we do about it? And that could be a 10-year response, managing it, so forth. But, and so you can see right away some of the impracticality of having the patient as consumer say, okay, who's going to give me the best 10-year management? I mean, the patient's probably not even going to be in town for 10 years. But I think that was the vision, that they would be chunks of consumable episodes of care, services that could be evaluated from a value perspective and selected by patients. And that would actually suggest a freedom of choice kind of all-inclusive set of health plan networks. So, we have those for sure. The tendency actually tends to be in this part of the country and a lot of other parts away from HMO and towards open-ended PPO arrangements where you do have pretty good choice. How patients are going to make that, I would hope it would be with the guidance of a primary care physician with the data and the insight to be able to do that. I do think the sort of the opposite way of doing that, and the way it's typically done, more typically done, is with narrow network health plans, as Alan Enthoven and others have suggested, some kind of managed competition where you have, you know, Atrius paired with a finance mechanism, for example, and MGB paired with what they used to call, well, I guess Always is this health plan. And, you know, if anything, we sort of moved away from that. I mean, Harvard Community Health Plan, as you know, Dr. Moore and most of you, used to be that, but it became all payer. And so there is no sort of marriage of the delivery system, financing system a la Kaiser to be able to select as an alternative to other providers. So I think it's a great question. I actually don't even understand how Porter thought that would work.
I have one comment. John, please call me Gordon.
That's your comment?
That was my comment.
Okay. Happy to do that, Gordon.
Well, excellent. I know that we're sort of running over time. I think, John, this was a fantastic overview and very provocative in terms of your thinking. Thank you. We'll see where that straight line goes, if there's a slight inflection point upwards or downwards. But much, much, much appreciated. Thank you for sharing your time.
Thank you, Joe. My pleasure.
Absolutely. And actually, our next speaker is offering to get your testing done for you so that you don't have to be in quarantine with PCR. Rachel Wilson, who you know well, John, is our next speaker. She's now president of CIC Health, who has played a critical role in the Commonwealth, providing convenient and ready access to COVID-19 testing and vaccinations. Many of you on this Zoom know that CIC was tapped by state leadership to run and organize several of the major mass vax sites, including the one at Gillette Stadium. Rachel here, working alongside Dr. Atul Gawande and others at CIC Health, pulled off what I would deem an operational logistical miracle, getting everything done for our state. And I'm super happy for to have her join us this afternoon to share her experiences and also her thoughts about startups and innovations in what I would call the public health space, which is another part of primary care. So Rachel's done a lot, been in several senior executive positions around Boston, was my partner in crime here as Chief Operating Officer at Atrius Health, and is very active locally in healthcare leadership. Serves on the board of directors of the Mass Chapter of American College of Health Executives. Rachel, take it away. Thank you for joining us.
Thanks for having me, Joe. And it's so good to see so many of your faces. I miss you terribly. And it's been great to see the work that Atrius has been doing throughout the pandemic. I'm going to tell the story of CIC Health and how we came to be and the role that we played, hopefully to be helpful to organizations like Atrius and communities at large. So I'm going to share my screen. And I titled this presentation, Breakthrough and Follow Through, how we came to support the nation's COVID-19 response. And I fully admit that I stole the term breakthrough and follow through from Dr. Gawande. He often talks about how healthcare is all about breakthrough and not enough about follow through. We love inventing things. We love creating new things. We love the next cure or vaccine. But we don't always love, or we don't always succeed at, making sure that that latest innovation, that latest cure, that latest treatment makes it to every person in every community everywhere. And so what we'll talk a little bit about today is our journey in the important role of fully deploying healthcare solutions out to the broader public. And I do think that there is a really nice intersection here between the efforts of primary care and then integrating some interventions more broadly through our public health infrastructure. So just a little bit about Cambridge Innovation Center, CIC, our parent. For those of you who don't know us, what we do is we create shared workspaces for innovators and entrepreneurs. And the whole idea is that by bringing the most bright, innovative, out-of-the-box thinkers together, we are going to fix the world. And you know, we have been doing this worldwide. We have locations throughout the US, Europe, Asia, and beyond. And when this happened, CIC really had to pivot because all of a sudden it wasn't really safe to come to work and to work in these shared workspaces and innovate and fix the world. Our CEO, Tim Rowe, was thinking creatively around how do I create confidence in the return to in-person work? So he did all the standard things, physical distancing. He's a real estate guy, so made sure that our physical spaces were set up to be safe. But the other thing he did was walk down the block, we're based at 1 Broadway in Kendall Square, to the Broad Institute of MIT and Harvard and said, hey, is there anything we can do to test our employees or our clients in our workspaces? And they said yes. And that program got kicked off pretty widely within our offices, and then caught the eye of Dr. Atul Gawande, who said, you guys are doing something really special and you need to be taking it everywhere. Let's co-fund a company and bring solutions beyond. And back in September of 2020, Atul wrote an article in the New Yorker about how we can solve the testing mess now if we want to. And his whole kind of point of view was, we've got to tame the spread of COVID. And the only way to do that is not just surveillance testing, trying to test at the population level, and not just diagnostic testing when people have symptoms, but doing something called assurance testing. And this is, let's test people once a week, twice a week, every week, in school, at work, in their recreational activities, so that people who are infected with COVID can quickly be removed from that environment, reduce that transmission, and make it safer for everyone else to congregate. And so, the belief pattern that we were founded on was this: assurance testing is the thing that's going to make it safer to return more confidently to our everyday lives. And of course, I just want to point out that it's not any one solution. The typical Swiss cheese, it takes a lot of different things to come together to ensure an effective response. But if you remember back to the early days of the pandemic, and I was with all of you at this time, as a healthcare provider, we had a demand for COVID testing. And very early in the pandemic, the CDC was saying the only people who can do testing is us, right? And then they slowly began to give approvals to more people. But there was all of this demand for testing, and we ended up going to Quest and to LabCorp, and we were waiting, 7, 8, 9 days for a test result. And I'm not a clinician anymore, but I don't believe that that was clinically relevant at that point, turnaround times of that speed. And so we had all of these organizations, from healthcare entities to businesses to schools, who wanted testing, but there was nobody identifying where that testing capacity could be. And it turns out that a research lab in Kendall Square ended up being a huge part of the solution, the Broad Institute. But there were other university labs and biotechs and manufacturers who had lab capacity that we weren't tapping. So Atul and Tim Rowe, the CEO of CIC, along with leaders from the Broad Institute, PWN Health, which is a national provider network, and IXLayer, came together and formed the Assurance Testing Alliance. And the idea was, our government isn't stepping in the way that South Korea was and other governments to pull together the labs and the providers and saying, hey, let's work together and solve this together. Let's make a private option to help support the public health infrastructure while we're waiting for a more nationwide response. And so what we eventually formed was a company, CIC Health, that powered this alliance. And what we bring is end-to-end testing services, later on vaccination services, together, testing, physician orders, the lab capacity, the software, everything you need to bring a testing solution to a lot of people. And we've kind of come along to think about, well, what is it, like, what is our purpose really? Like, is our purpose just to do COVID testing? That's not really inspiring. There's a lot of labs that are out there. There's a lot of physician groups. There's a lot of health systems. There's Walgreens, there's pharmacy. There's a lot of people that are out there that can deliver this service. But the unique role that we wanted to play was to be able to help public and private entities, so state governments, cities, municipalities, as well as corporations, prevent serious pandemic-related illness and suffering by ensuring that these known, proven public health interventions, assurance testing, vaccination, scale to communities everywhere. That means kids who are at school, that means individuals who are living in correctional facilities, our elderly who are in all sorts of settings, from home to skilled nursing facilities and beyond, getting their hospital care at home, as well as just individuals who are going about their day-to-day life and want to have testing so that they can go have Thanksgiving dinner with their families. And it's been really interesting. This is just our case study, or not case study, but our experience. The demand for testing has been really weird. It went up quite a bit, and we were very busy last winter. And then as the vaccination process rolled out, we obviously saw testing demand tank, right? Corporations are like, why am I going to test our employees and pay for this if they can get vaccinated now? And schools were letting out for the summer. So around June or July, I think I called Joe and said, I don't know, this business we might have done our mission and we might not be around a whole lot longer. Let's talk about, like, let me pick your brain about my experience in public health and what I can do from here. And all of a sudden Delta showed up, and you can see what's happened ever since. And now we can, continue to work through the Greek alphabet, but, we are busier than we've ever been. And back at our peak here, we were in 20 states. Right now, we're basically working in 4 states. It's just fascinating, just the amount and intensity of testing business. And just in case you forgot last year, what happened around this time of year, we were kind of cruising along, getting things under control. And then it started getting cold and people started hanging out together inside, and there was more transmission. And then, all of a sudden, like, Thanksgiving happened, and we had this huge 2x spike in the number of cases, and it continued to grow after Christmas. And so we are in a surge. We should expect to see that surge continue to grow. And the existing healthcare infrastructure hopefully can support it, but maybe not fully. And so there's a place for companies like ours who help to bring testing services, vaccination services forward to help supplement in moments of great surge, when the existing healthcare infrastructure might also be focusing on flu-like illness, all of the primary care needs that they're facing because healthcare has been delayed over the past year. I just wanted to give you a quick note about what we're principally doing, and that's mostly testing in the schools. We're doing a lot of public testing. We're in about 40 different locations, but a lot of what we're doing is school-based testing. And as you know, children weren't until recently eligible between the 5 and 11 year age group for the Pfizer vaccine. So we know that the risk of spreading in schools, if kids who don't really like to sit in their seats and keep their masks on are all sitting in close proximity. And so we offer 3 types of testing in the schools. One is symptomatic, right? If you have symptoms, you're sniffling, you're coughing, you kind of seem a little COVID-y, we'll give you a Binax Now antigen test. And in Massachusetts, you're allowed to stay in school if that antigen test comes back negative. We also do a program called Test and Stay, which is if for some reason there's been a known exposure in the school, and it could be that, I don't know, I'm gonna make this up, Chris Andreoli's kids came back from Thanksgiving break and mom called the school and said, little Johnny was, tested positive for COVID yesterday, and I know he was in school, I just wanted to let you know. In the past, all those kids that came into close contact with Johnny had to go home. Now we've implemented a program where we test students who are close contacts for 5 days in a row with an antigen test, and if they continue to stay negative, they can stay in school. And so far this year, we've saved over 200,000 school days in Massachusetts alone. So just to give you a sense of like the size and the impact, this is primary care, right? This is prevention. This is delivery of primary care interventions in a public health setting, right? It's like when I was a kid, I got fluoride to make my teeth stronger when I was in school. They put it in my water, and sometimes we give it in our doctor's offices now, but it's making testing part of our everyday life. And the other thing I would just say is we do something called pooled testing in certain school districts that elect to do it. And you all know what pooled testing is, but the idea is that every week we're testing as many people in the school that are consented, and it's very inexpensive to do it this way. And you do this in environments where it's likely to be very low positivity rate. So you can test a lot of people and confirm a lot of people are negative. And then when you do have a positive pool, you go back and you test the individuals. And this has been like really, really effective. And right now, when so many kids are coming in with close contacts or with positive cases, they've made a lot of close contacts in the school. Pool testing becomes much more efficient than individual testing. But switching gears, I just want to tell you a little bit about vaccinations and come back to the thing I talked about earlier, which is it's really awesome when we create cures or we create tools that help to reduce the severity of illness or the risk of hospitalization, like vaccines. But vaccines in and of themselves don't save lives, right? It's vaccinations that do. We've got to make that solution get into the arms of every individual who is willing and interested in receiving it, and maybe those that aren't. And so again, it's going that last mile. What do we need to do? And we're really known for the work we did at mass vaccination sites like Gillette Stadium and Fenway Park and Hines and so forth. And we did about 1.14 million vaccinations in that environment. But we also got onto container ships when people were coming from overseas and delivering packages, like, you know, those big containers. We vaccinated people when they were in port. We went to animal shelters and vaccinated people when they were coming to look at animals. We were in church basements, we were in schools, we went to the science museum and we got to teach kids about vaccines while we administered them for 12 and up at the time. And so we only reached about 40,000 people during that effort in the community. We went to about 135 different locations, much less than what we did at the mass vac sites, but perhaps more important, because what we were trying to do, I don't know if you guys have seen this take on Shel Silverstein's The Giving Tree. We were trying to not just address equality, where the same tool is everyone gets a vaccine. What we were trying to do was get to equity, where we found the right way to administer vaccines to people based on their individual needs. Hopefully we get to a more justice-based approach in the future where the system is not so inequitable. Everyone can get to equal opportunities and equal tools, but we're just not there yet. I'm gonna wait for the question and answer period, but I'd love to talk to you a little bit about how we broke down barriers to reach some of our most vulnerable community members. I'm not gonna read this, but one of the most impactful experiences of this journey for me was when we went to Reggie Lewis at Roxbury to launch a mass vaccination site. It was back in late February. And at the time, the group that was eligible were those that were, I think it was 75 and older initially. And what's really fascinating is that when you go into that community and you look up the demographics, the gross majority of people do not live over 65 years of age. And so here we are thinking, you know, on behalf of the state, setting up this awesome program in a community, but not many people in that community were actually even eligible. So at that point in time. So, I mean, I think in closing, you know, we know that in some time in the very near future, vaccine and testing supply chains are going to be solid, and that's not going to be a go forward issue, hopefully. We know that more and more people are going to be eligible for vaccinations. And so we're going to probably see some demand drop. On the other hand, cases are up. There's new variants, right? Omicron. We don't know how long the boosters will last. We still don't have a great nationwide delivery system for like real-time treatments like monoclonal antibodies or the Pfizer pill. And, you know, at some point in time, like right now, there's a sudden surge for vaccination. We were being told by the state, and I'm going to stop sharing now, that there's never going to be a role for a company like CIC Health in vaccinations again. There's no way. You guys are just overhead. Like, we probably won't need you. And then sure enough, Secretary Sutters calls the other day and says, well, just kidding. Omicron has really driven up a substantial need for vaccination services. People can't get an appointment anywhere. Can you help us stand something up? And so the whole point of CIC Health is to enable the existing healthcare infrastructure to work better and to allow you to do what you're here to do every day, but take some of that burden off of you. And hopefully, eventually, influence our nation in developing an even stronger public health infrastructure where we really aren't investing today. So that's a little bit about our story.
Rachel, that's awesome. And I will stand by my statement that it was an incredible feat that you guys did to actually be able to provide the types of services to the Commonwealth that CIC Health did. So hats off and kudos to you. Let me begin with a question of sort of, I think it's laudable to think about a service like CIC Health that complements into the delivery systems when needed or when we're getting crushed and overwhelmed. But to the point that you just discussed, the ebbs and flows, the needs, and then the complete lack of need at times, how does that sustainable for CIC Health?
Yeah, that's the $1 million question we're focused on right now. I think that we've been talking a lot about this because the truth is, right now, I wasn't able to say to Secretary Sutters, I'm ready to stand up vaccination again because I let my whole team go, right? And we got rid of our ultra cold freezers. Not that we need them anymore, but like we got rid of everything. We'd have to rebuild, and I don't know if we could rebuild fast enough. And so it has led to some very interesting conversations across the different states that we have sole provider partnerships with. And I think that there is a recognition that the existing boards of health provide an important purpose, but when you go to many of them and work with their local head, they're like, I know sewers. I don't really know anything about like vaccinations, or like, I have like 2 part-time people who work for me 5 hours a week. How am I going to help? And so I think that part of this will be creating a case. If we wanted to take a public-private partnership approach, would be to create a compelling case that we are available to provide certain ongoing services in our board departments of health, but can redirect our attention when needed into a different kind of approach to help support something like an earthquake or a hurricane or a pandemic. The other thing is, I've been having some really interesting conversations with some of our unique business partners. So one of the groups that helped us to launch mass vaccination was Dempsey Sports. This is the group that puts on marathons all across the country, including the Boston Marathon. And the CEO and I started to imagine a world where, what if Dempsey, this is like not public information, guys, but this is like brainstorming. What if Dempsey was part of CIC Health, and CIC Health ran marathons on an ongoing basis, but when a pandemic happens, marathons aren't happening, and you have a whole workforce of people who are available. I'm using that as a silly example, but what are the kinds of things that you can do in the health and wellness space? What are the things you can do with your local boards of health to make them operate better and maybe even get regionalized, if not? I can talk quite a bit about that. But there are needs. And so we just need to figure that out, and hopefully can convince states to support an ongoing relationship beyond the kind of episodic events like this.
Yeah, oh, that's great. And Daniel, let me turn it over to you.
Yeah, I likewise echo Joe's gratitude and awe and appreciation for all that you and your company have done over the course of the past couple of years. As a parent of children who've had their noses swabbed by your company many times over the past school year and a half, even if they're not grateful for it, I will express my own gratitude. One question that I have that often pops up on my Twitter timeline are colleagues and friends who happen to spend some time in the UK or elsewhere in Europe are shocked at just how available rapid testing is to them. They can walk into a pharmacy and walk out with a 7 to 14 pack or whatever of them. Why aren't we there yet? And what are the next steps needed to make rapid testing truly universal?
Yeah, I mean, I think that question becomes like much larger at an international, like global supply chain approach. I think there's also decisions that we make at the federal level and the state level here in Massachusetts that help and hurt that. So for instance, I happen to think that there are hundreds of thousands of Binax Now tests sitting in closets in our schools today that aren't actively being used. Like, what is the governance process in a time of constrained supply to make sure that the resources that you currently have available are deployed and not hoarded or ignored before they expire? One of the biggest tragedies that we have is the pace of which precious testing kits are expiring before they actually go use. And yet there's this tremendous demand. And so that goes back to, from my perspective, back to the beginnings of CIC Health. There wasn't a national position on what our nation needs and what we expect of our manufacturers, our healthcare providers, our public systems, and how we are going to work together with a common goal of doing what's right for all Americans and maybe everyone worldwide, given this pandemic's nature. So I think, I think that it takes leadership at all levels. It takes leadership at the state, federal, and global level.
Yeah. That's great. Again, invite folks to either type in questions or raise your hand for Rachel. And let me do, actually, before I go on, Dan, do you have another question? Sorry, I think I just cut you off.
No, I appreciate your response to that. I hope that someone does step to the plate to, obviously it's a bigger issue than, than any one organization can be expected to tackle.
Well, let me ask Rachel then, when you think about primary care systems like Atrius overall, right now it does feel like you've talked about, augmenting the services of the school boards and other places, other things, other services in the community that we actually aren't that well integrated with, right? We're not coordinating that. Maybe in pockets there are, as, maybe in Watertown and other places, but how do you see any public-private sort of partnership like this interfacing back with the traditional healthcare delivery system? We heard Pippa earlier talking a little bit about other services going into the homes, et cetera. We heard Chris talk a little bit about remote monitoring and other things happening out there. Looks like you've got another wedge of this, which is a key part of health, right, overall for a community, but it's being optimized in a way that, there's no way Atrius could do something like what you just did, or any delivery system, because you guys are focused and capable and had that expertise brought together. How do you think about that role in is it fragmentation? Is it optimization? How do you think about that?
Well, I think, I think a lot back at my days at Atrius and how painful the day-to-day existence of a primary care provider can be as it relates to the burden, the administrative burden, and the inefficiencies of the tasks that have to be performed in the primary care setting. How do we get people back for their 30-day blood pressure recheck, or their hemoglobin A1C, or their asthma medication ratio measures, and all of that kind of stuff. And I think a lot about, and I've admittedly asked Joe a little bit about this, like, are there things that an organization like CIC Health, in the context of people's lives out in the community, because we haven't done just mass vaccination sites and public sites. We literally walk door to door with backpacks and vaccines in certain high-risk communities. And I think about Pippa's work around hotspots back in the day. And like, can we imagine if we look at your populations in certain pockets that their basic primary care needs are really hard to deliver? Could someone like us help take some of that lower level work, but necessary preventative care off of your hands and deliver it for you in the context of people's homes? Now, Atrius is already 3 steps ahead of that, right? Like, you have so many home-based programs. Most practices don't, as was stated earlier. So I would love to imagine with organizations like you, what would be useful to have somebody else helping you with in a highly integrated way that gets you to the outcomes that you're seeking to deliver. Because the more we deliver health care in the context of people's lives, the better able we are going to be able to drive towards health and the reduction of suffering and the improvement of quality of life, right? And so I don't have an answer for that, Joe, but I would love to imagine that together with people like you who are out there doing heroic work every single day for the people who call you, who chat you, who video you, who come into your offices. But there's got to be stuff that's weighing you down, that maybe there's a different way of doing it. We know there's a different way of doing vaccines.
Yeah.
We know there's a different way of doing testing.
Yeah.
Maybe you guys can help us solve that.
Questions, final questions for Rachel and the team. Use either the chat or raise your hand. Bob, did I see a hand go up there? You're smack in the middle of my screen here, so.
Well, maybe, yeah, I'll ask a question. And I did have a member of my family get tested with you, Rachel, and I very much appreciated it at the time. I noticed the remarkable disparity in access to testing and cost of testing in our society. I was lucky enough to get testing because I work for a healthcare organization. It was required for travel. Initially, Atrius wasn't doing that, but then they changed their mind, and I was grateful for that. The Broad was providing testing through Cambridge residents and employees at no cost. Other organizations like you were doing testing, but I suppose we're not supported by the kind of grant that the Broad had. So we're charging for it, which your organization has to survive. But what I'm amazed about is the amount of free testing, the amount of cheap testing, the amount of expensive testing, all to do the same thing to enable us to control the pandemic. And what kind of a bizarre, disparate situation is that when all we're trying to do is we're all trying to do the same thing, regardless of where we're getting our nose swabbed. We're trying to keep ourselves and everybody else in society healthy, yet it costs between $0 and sometimes $200 to get the same thing.
Yeah, so I think it's a really, really important point. And just for those of you who may not be familiar, CIC Health has 2 public testing sites that are privately operated by us. We have 43 public testing sites and thousands of individual locations where the testing happens at no cost to the individual. So we perform about 25 to 30,000 tests per day with the Broad and a couple of other lab partners. Probably 300 to 400 of them are paid out of pocket. So just 30 to, about 30,000 a day, about 300 of them are paid for out of pocket. So when we first got started, the reason that happened is when we first got started, we didn't yet have government contracts. And there was a demand for testing that wasn't getting met in our existing healthcare infrastructure, and we needed to get experience. So we launched these sites, and yes, we had to pay for them. So we charge much less than most of the other PCR vendors that are out there, but we still charge $80 or $70 if you know me. So by the way, if you know me, you can get that for $70. But so just text me. We went to the state governments. We went to Massachusetts and said, we know you're starting the Stop the Spread program. We want to be a provider. So we're actually a behind the scenes provider at many of the Stop the Spread sites at Massachusetts. You might not know that, but you may have visited many of our sites. We all of our 35 locations in Vermont are completely free to they pay for taxes, but they're free to it in terms of going to a public testing location. All of the school-based testing that happens every day is happening at no cost, the prisons, et cetera. So, but it's paid for by our state governments and by FEMA, and it filters down to us. But we really agreed with you, and it felt very inauthentic when we were only offering a pay out of pocket option. And that's sort of how we ended up getting onto the path of going to state governments and saying, hey, let us do this for you, and let's find a way to make cost not the reason that gets in the way. And then we started to tackle other issues like geography in Vermont. You guys know how big Vermont, I had no idea Vermont was big. It looked small, but there's like mountains that get in the way of everything. And there's like different ecosystems everywhere. Yeah. Their governor's goal was to make sure that we had a testing site within a 30-minute drive of every Vermonter, and we did that. And so we tried to look at access economically, geographically, making sure we have people that speak the native languages that are most frequently spoken in different areas, so much to address access. But I agree with you, Bob, what a messed up system. Yeah. That it requires all of these different options to get there. I tried to buy antigen tests on Amazon yesterday and couldn't do it.
Yeah. Well, no, Bob, great question. Great. And I know it's a little bit of a downer topic to think about the inequality that's baked in completely into our systems right now. And it's something that everyone on this Zoom is probably very passionate to try to figure out how we can contribute to make things better going forward. Rachel, I want to thank you again, not only for what you've done, and I know that you've personally been involved in a lot of helping push CIC to do what it's doing, but again, also for sharing your thoughts and sharing your story with us today, because I think it's a very cool, again, another side of public health, of primary care that's being sure, disrupted is probably maybe too harsh of a word, complemented, thought about differently. And I think it's a really cool thing. And I think we need to keep an eye on other domains that are probably coming in this space as well too. So thank you so much for sharing.
Thanks for having me.
So, you know, last 5 minutes, we're going to close on time. Daniel, what have you heard? What do you think? And again, one of the areas the past couple of times we've done this, we've definitely tried to take an angle around what we've heard indicate of how we need to be thinking about medical education, right? Education of primary care going forward, about what that job is going to look like. How do you think about that? How do you integrate this and reflect on it?
Yeah, for sure. I think looking at this from an education lens, thinking about the primary care workforce of the future, we've heard from everyone today that it's going to require flexibility, not just in terms of how we think about medicine, but how we think about where care is delivered, how we think about giving access to patients to us, to our care teams. It's about rethinking what it means to care, to help support people's health. I think reflecting back on what Pippa was saying, how do we go beyond saying this is what primary care is, these are the set of services that we're going to deliver, to say, okay, actually, what does our patient want? What will support them to help them live the sort of life that they're looking for? How does that integrate into a residency training program? How does that integrate into medical school? Yeah, I'm a huge advocate for our particular residency program. I think Atrius and the Brigham have struck up a pretty remarkable partnership. So a little bit of this is preaching to the choir, as it were. Mm-hmm. The ability that we have here to flexibly use our time, to control our curriculum, to be here moderating panels like this is unique. It's certainly not a widely available opportunity. So I think if we are expecting the primary care provider of the future to be flexible with the way that they're thinking about caring for patients, we need to give them flexibility even in residency to start exploring these questions, to start thinking then about how they're going to change.
Yeah. No, that's a great point. Yeah. And as I think about what we've heard today or this afternoon, the other interesting thread that seems to come forth as we all think about the future, I think Gordon asked the question, how do we start competing in this space around value? And John's response was, well, the theory may have been around these episodes. And I can't help but to think, the what and the how is really being disruptive of primary care. The what being things like what Pippa talked about, and new ability to monitor things that we weren't even able to do before. The what is changing dramatically, and the how, vaccinations, things that we've always have been doing, but there are potentially more efficient, more effective, more scalable ways of doing that happening to us in different parts. And that concept of competition in this space, how do you compete with the CIC on vaccinations, right? That's a really hard thing to think about if you're a traditional delivery system. But many of those areas and many of the fragmentation pieces, again, as a primary care clinician, I think we all get back into the space of our role in many ways is to think about the entire human patient in front of us, right? And help piece together all those elements. You have optimization in A, B, C, D, X, Y, Z. How do you integrate that? How do you help a patient think about all of that pulled together? And I think that's one of the things that both Chris and Pippa also hit upon in their talks. Well, I want to close out here realizing we got 60 seconds left. I do want to thank all of our speakers this afternoon for sharing their thoughts with us. I learned a lot. Hopefully most of you picked up some things along the way. I do want to give a quick shout out to the dedicated folks from the Atrius Health Academic Institute who are on this call as well too, help us host this forum. Jenny, Kelsey, Amy, and Amal, thank you very much for your help. And I know Maddie's also subbing in here from Clinical Affairs. Appreciate her help. And then a quick thanks to Dr. Nelson, my co-host for this forum, for stepping up and helping your contributions. And a big thank you to all of you, current and future primary care clinicians and healthcare leaders. Really appreciate the work that you do. And thank you so much for participating in this year's forum. Appreciate it and have a great night.